Thank you so much, Julie, for being here. And you're going to be talking about the physiology of aging skin. I think it's really important that we understand that when we are facing some of these challenges with skin conditions. And I know you're exactly the person that is going to tell us all about it. So I'm hand over to you. Thank you very much.
Good morning, everybody. I know there's a lot of you attending today, a lot of interest with this really important topic about older skin, or people with who are older with skin issues and relating to your area of tissue viability and skin integrity. So I'm starting off the day with a talk on the physiology of aging skin. Now, I think for most of you, it will be quite a lot of revision. So I certainly didn't want to do a straightforward anatomy and physiology talk, although there's quite a lot of that in it. I wanted to relate it very much practically to the patients you're seeing and your everyday practice. So I hope it will be a helpful talk, and I hope you enjoy it. And please do ask questions as I go along in the chat box. Sarah and the Pink team will be collecting those, and then we can have more time for discussion at 10:15. So we've got plenty of time for questions, so please ask lots. So as Sarah said, my name's Julie Van Onselen. I've been a dermatology nurse now for 31 years, and I mainly have worked in primary care. I did start off in secondary care, but actually my real love is primary care dermatology. And I do work independently. I always say I'm a little bit like the emollient. I'm 50-50, 50 clinical, 50 practice. At the moment, my practice is mainly in skin cancer. And I'm going to talk about skin cancer in this session because I think it's really important in older people, or in all the population, I should say. But I think you'll be quite surprised at some of the statistics. I also do a lot of teaching and lecturing, and the two societies that I work very closely with, the National Eczema Society 1 day a week as a clinical advisor, and also the Primary Care Dermatology Society. So the Primary Care Dermatology Society is a very useful society, and it's a medical charity for the whole range of dermatology. Now, the great news is the website is totally free and it's literally updated every week. It really is a fantastic resource. And again, there is membership if you wanted extra things like our bulletin, which really is more like a journal, and also our sort of in-house sessions for education, and in particular, the skin clubs. But the website, pcds.org.uk, if you haven't discovered it, is a brilliant source, free to everybody for dermatology education. So a little bit of a plug, but really more as a resource for you. So I'm going to talk about the physiology of aging skin. And what we really want to do by the end of this session is to help you understand more how aging skin changes can compromise wound healing. And then to be alerted very much to the actual differences between exogenous and endogenous skin aging changes. I really want to focus on the impact of photoaging because it very much is an area of my practice. And I think it is often slightly forgotten sometimes in terms of this sort of lecture. So I think we will talk about the instant risks and signs of skin cancer in older people, which, as a lot of you know, can actually result in problems with skin integrity and indeed even ulceration. So aging skin changes and the actual impact on skin healing and wound care. So we all know that older people who never know quite where the age definition is, but it is over 60 years, which slightly depresses me. Anyway, can be compromised. So the skin can be compromised, but certainly we do know that from 60 onwards, these physiological changes really start to occur as the result of skin aging. And the complications seen in surrounding skin actually can compromise wound healing. In addition, environmental factors can really add to the risk of these skin complications as well. And it's an interesting fact that in patients over the age of 65 years, 56% suffer from exrosis or dry skin. So exrosis is often a medical terminology from dry skin, and 9% will actually experience more moderate to severe exrosis, which might even result in developing eczema or other dry skin conditions in the older person. So let's look first of all at the structural anatomical differences between young and old skin. Now, I was just thinking, how would we describe, or how would somebody who was older describe older skin and older changes? And I was thinking, to actually describe what's happening in the skin, we need to think that when people are over 60, 65, skin becomes drier, it becomes thinner, more fine lines and wrinkling appear. It becomes fragile, much more prone to skin tears because of the thin skin, which then, as people become older still, in their 70s, 80s, skin becomes pale, becomes translucent because it's thinning even more. There's loss of elasticity. So you have sort of sagging skin that's lost its elasticity. It's not as robust. And that sort of fits in also with thinning and drying. And then, of course, you get the appearance of lots of different lesions on the skin, lentigo, perhaps affectionately known as age spots, broken vessels, keratoses, the big crusty seborrheic keratoses or other keratoses, and of course hyperkeratoses, which can again be quite a big problem for surrounding skin issues and skin healing generally, and can also cause skin breakdown itself. So when you think of all these sort of areas of where the skin is changing and what you're seeing in the older skin, what is actually going on? So what we know is that the stratum corneum, basically you've got the layers of the skin, your stratum corneum, your epidermis. Between the epidermis and dermis, you've got your dermal epidermal junction, and then you've got your dermis, your papillary dermis and reticular dermis, and then the hypodermis. So basically everything is becoming a lot thinner. So you see the stratum corneum is compromised, and you can see this. I'm just trying to find a pointer. Very much, you can see the thinning of the skin. Sorry, gone too far. So the stratum corneum is literally the outer layer of the epidermis, and this is what we also call the skin barrier. It's very compromised, and we've got another slide that talks about this in more detail, because lipids are reduced, and most importantly, the natural moisturizing factors that normally keep skin very buoyant, particularly and robust, particularly in younger skin, are reduced. Now, you do see a reduction of NMFs in some other skin conditions, and eczema is a good example, connected with the filaggrin gene. Anybody with eczema, or 50% of people with eczema, will have a reduction in natural moisturizing factors. And these are factors such as urea, hyaluronic acid, glycerin, etc. Then the actual epidermis actually thins, and it actually thins by up to 50% by the age of 80 years. So that's why you do have this very thinning skin. And in addition, the dermal epidermal junction, which is a protective layer between the epidermis, and in the epidermis, your corneocytes are moving up the epidermis, becoming keratinocytes, and then scaling off. That process in itself slows down, and that's why you get scaly, thicker skin. But also the flattening and weakening of the dermal epidermal junction actually reduces the protective layer between the epidermis and the dermis as well. And then generally you have a decrease in the thickness of the dermis. And we know within the dermis, there are sensory and pain receptors. So there's loss of sensitivity, these reduce. You've got sweat glands, and sweat production is reduced as well. And then you've got Langerhans cells for immune function, and these are all decreased in numbers. And collagen. So collagen is part of the dermis, and collagen starts to break down in older skin, and so you lose this elasticity. The hypodermis is basically the link between the skin and the fascia. and the hypodermis also decreases in thickness. So all of this leads the skin to be a lot more vulnerable. So this is a great diagram because this really explains about the skin barrier. So we're going right back up the top to that stratum corneum. And did you know the stratum corneum is the same thickness as a piece of A4 paper? So it's literally this thick. But it's so important because it's our absolute skin barrier, and a lot of skin problems with skin integrity and skin breakdown is because of the skin barrier being compromised. So it's important to look at when it's not optimal. And you will see universally, it is not optimal at all in older people. So going from cradle to grave, because it's quite interesting to look at this, in babies, the stratum corneum is only 70% developed, and it needs to develop by a further 30% along, actually, with some other structures within the skin. So the skin is the only organ at birth that is not developed into a life form in a way. So the skin is compromised, and that's why you see a lot of babies with transient rashes, dry skin, seborrheic dermatitis. Anyway, we're not talking about babies and children, but at 1 year old, and this is people who do not have skin condition, you have an optimal skin barrier. Unfortunately, it starts to go downhill quite a lot at age 50, but when you get to 60, you're in this yellow zone where the skin barrier for anybody over the age of 60 is not optimal, purely because of the aging changes. Of course, you get dry skin. Sorry, I don't like this expression, but it's a borrowed slide. But obviously older dry skin, winter xeriosis due to environment. You get a lot more pruritus, a lot more itching because of the skin barrier, being compromised. And this can lead to a type of eczema that you only see in older people, a physiological eczema called steatotic eczema. Going to see a picture in a minute. Now, underneath here, because this is a slide about eczema really in lots of ways, atopic eczema, 50% of people with atopic dermatitis, their skin barrier is not optimal. So anybody with atopic dermatitis has a compromised skin barrier. And what can happen is if an older person has had atopic dermatitis or atopic eczema as a young person, and even if their eczema's got a lot better in the middle-aged years, quite often eczema can come back with a vengeance in older people. And that's really important because eczema is a condition that relapses and remits. So it is quite common for eczema to return. And certainly there are other types of eczema that you will see more predominantly in older people or people with venous insufficiency, such as varicose eczema. So that just talks about that skin barrier. And to explain it a bit more, we always use the brick wall analogy, which I find very useful. So if you think normal skin, if you think of that optimal barrier, it's impermeable to irritants and allergens, and it sort of prevents water loss from the body. So you've got very robust skin with a high level of these natural moisturizing factors, which attract water, help the corneocytes swell, so they give resilience, which basically stops irritants and allergies getting in and water being lost. You've also got lipids that surround the bricks, rather like cement, including ceramides. So lipid lamellae also helps keep this high water content. So again, dry skin conditions, not only eczema, we should mention ichthyosis as well, perhaps, and also we see it in psoriasis, but predominantly in eczema, you will see a reduction of 80% of natural moisturizing factors throughout life. So older people who do have eczema as well are even more vulnerable. But anybody over the age of 60, these natural moisturizing factors reduce and the lipid lamellae becomes defective. So basically the skin becomes more like a dry stone wall, which is crumbling with the capping actually disintegrating. And you can see environmental factors can easily penetrate the skin and water can easily be lost. Corneocytes shrink, causing cracks between them. And this also then in turn triggers an inflammatory response and actually then can actually trigger the response of eczema. Now, the best treatment for this, of course, is emollients, but I certainly won't steal Rebecca's thunder. So this is a really good prelim, really, to your emollient talk a little bit later. So this is really interesting. So that you can see here, this is normal aging. This is actually a picture of an 80-year-old who actually did not have, say, they had any skin condition, but you can see the skin has lost total elasticity. There's lots of sagging, but you can see there's lots of dry, scaly patches. And can you see some excoriations? So this person has probably been scratching and is quite uncomfortable, and skin is very dry. So that's a compromised skin barrier due to aging. But as I say, this person didn't feel they had eczema. They just felt they had dry skin because they were older. You could say, I could almost say this was low-grade eczema. Whereas osteototic eczema, which is a physiological eczema that appears in older people due to breakdown of skin barrier, you often see this on the lower legs, and this in turn maybe could contribute to skin breakdown and even lead to ulceration in some cases. But what you see is you actually see the breakdown of the barrier. So you can see this almost, if you imagine your brick wall, you can see the top of the brick wall is really, really cracked. We sometimes call it eczema craquelé or crazy paving eczema. And you can see amongst all this intense dryness, a bit of sort of scaling, maybe some hyperkeratosis might build up as well. You can see a lot of inflammation. So this then becomes a physiological eczema that needs treating as such. And again, lots of emollients and also some topical treatments to reduce the inflammation. So let's go back and look more at some of the changes which we've called endogenous. So endogenous means changes from within. Now this is quite complex, and there's lots to say. So I've just really picked out a few points. You certainly can go to the references I've given for more reading. But I think basically in older skin, there are a lot of cellular changes. We call it skin involution. So rather than the cells proliferating as they would in sort of younger skin or, healthier younger skin, you get this decrease in cellular activity. So you don't get the proliferation of the corneocytes, which are gradually moving up the skin, and you get shrinking of this dermal epidermal junction, which changes this extracellular matrix in the skin. So all these cellular changes are the things I described before about the thinning. You get reductions in dermal mast cells, in fibroblasts and collagen, again, which make the skin more vulnerable. And the collagen synthesis actually decreases. So that means that the skin really loses its plumpness. And that's another reason for sort of the sagging of the skin as well. And of course, the cellular changes, as I've described, they affect the skin thickness because the skin is thinning, and the hydration. Acidic balance and maintenance of acidic balance is really, really important. And this is another really good role for emollients, because emollients really do help reduce the acidic balance of the skin to a pH of 5, which is a healthy pH balance. But as I'm sure you know, washing with soap and bubble baths and detergents will actually shoot that pH balance up to a more alkaline level, which will cause breakdown. So that I'm talking about some external factors there. But the key thing is that skin pH internally actually increases with age. So actually, skincare is even more important, particularly emollients and not washing with soap and washing with emollients to bring down the skin pH, which in the endogenous form is increasing, because if a skin pH is high, that compromises the skin barrier and breaks down the skin more. And also, again, when you've got skin breakdown, you've got increased infection risk as well, because you've lost that protective layer. Now, there also are some general ethnic and gender differences. So I won't go into lots of different skin types because I haven't got time, but it certainly could be a great topic for another day. But I think, that there are some genetics and ethnicity differences as well. Reduced vitamin D levels, I think, is really, really important. Metabolism of vitamin D slows with age. Now, I know you're probably very aware of it, and there could be a whole talk on vitamin D as well. But vitamin D levels should be checked, particularly if older people do develop difficult eczema, because low vitamin D is certainly linked with atopic dermatitis. And obviously, older people should not be relying on sun for vitamin D. as you get older, you need a much higher level of vitamin D. So you're much better to take oral vitamin D, because what we know is that naturally 90% of vitamin D comes from the sun and 10% from food. But older people just often, and actually people with low vitamin D levels can't rely on sun alone because of the detrimental effects. So I would say keeping an eye on vitamin D levels, particularly if you've got patients with difficult eczema or skin problems, is really, really important. So endogenous facts coming from the outside, we're going to talk about sun in a minute. You've got a reduction in, still on endogenous neurosensory function. So the perception of superficial pain actually diminishes in intensity of the speed of the pain receptors, but perception so in that way the thermal injury risk is much higher. And we've all seen people who've perhaps sat too close to the fire and have burnt their legs and haven't realized it. But pain does increase in intensity for older people in terms of deep tissue pain. So we've all seen that with our patients with ulceration. Core temperature does reduce, and this does affect the ability of the skin to thermoregulate. And of course, alongside that, you get decreased sweat productions. Again, lots to say about vascular function as well. The microcirculation worsens, and the number of small blood vessels and capillaries completely decreased. So you haven't got a capillary bed that's going to be, nurturing a wound and helping with healing. So this reduces by a third from between the ages of 40 and 90. The capillary vessel bed in the skin actually reduces. And venous insufficiency and varicose eczema illustrated here more common. Immune function decreases dramatically as well, and the Langerhans cells, which are responsible for the antigen-presenting cells, decrease. So again, you've got much more susceptibility. This affects healing, makes people more susceptible to infection, etc. There are lots of physiological age changes, and with some of these, you can actually do something about it. So I'm going to talk about sun and radiation in the next slide. But the interesting fact is that people who live in urban areas with very high traffic pollution, perhaps, not so much in the UK now, but in some urban areas, but certainly in maybe other parts of the world, traffic fumes and fossil fuel ingestion can age the skin. We absolutely know about tobacco and cigarette smoking. There is an absolute link with skin aging. So the worst thing you can do really is have lots of protected sun and smoke. I don't know about vaping, but I would imagine there may be more research coming out, but we would certainly discourage smoking. Certainly stress links with lots of skin diseases, and when people have pruritus, it's very difficult, as well as being stressed by itching. There's a lack of sleep, and lack of sleep, of course, can be something that older people can actually find something that really compromises their whole life. But actually, it can also accelerate aging changes as well. Temperature, it tends to be, and this is not related to sun, this is about temperature in itself. So it tends to be that heat is more detrimental than cold. There were some interesting studies done with bakers who are obviously exposed to hot ovens, and also glass blowers, which was very interesting. And these studies showed they had accelerated aging because of occupational exposure to heat. Nutrition is really interesting, and I think there's a lot to say. It's not entirely known, but it is thought that a high sugar diet is detrimental to collagen and will break down collagen. And actually, as always, a healthy diet rich in antioxidants, particularly fruit and vegetables and vitamin C, is positive to reduce skin aging. And certainly the Mediterranean diet is more positive to help maybe reduce some effects of skin aging. So I think it's a similar message, which again is quite hard sometimes with sort of accessibility to food, cooking, and fresh fruit and vegetables. But the healthy diet does help reduce skin aging as well. And there's a very good paper which has a lot of this in. So now I just want to talk about photoaging, because I think this is really important, and also a little bit about more the higher risk of skin cancer in older people. So when you talk about the physiology of aging, obviously we've gone through the exogenous factors and the endogenous factors, but photoaging is often seen as the third factor, even though it is an exogenous factor, it's seen as the main factor. And what we know is that sun exposure accelerates chronological aging and causes skin damage and skin cancer. This is a really great picture. Some of you may have seen it before. It's quite an old picture, but it's actually a US truck driver. And this part, obviously driving on the other side of the road in the US, but you can see occupationally his face was very, very damaged with lots of we call it some solar elastosis, and you can see that the actual sun damage, the heavy sun damage on one side of the face, because that was where the sun always caught him. Obviously, backs of hands, we see lentigos. So lentigos are basically pigmentary changes as the skin thins, and this is due to overexposure of UVA. And then you can see some more thickened, rough skin through chronic photo damage as well. So basically, there are lots of sort of causes of photo aging, and the main rays are that UVA is the main reason for aging the skin, wrinkling, lentigo formation, and this is in the atmosphere continually, and you've got two UVA rays. So the UVA1 is the deeper ray that will cause this continual photo damage. And UVB, we often relate B to burning. So UVB are the burning rays. So you've got UVB depending on the amount of UVB in the atmosphere. So that's why we have the skin index on the weather and things. So it's really important to protect against burning, because burning again will accelerate aging, but burning also is responsible for triggering many skin cancers, particularly melanoma and BCC, whereas UVA and overexposure of UVA leads to actinic keratosis, which then is almost the warning sign, or the fact that that this could lead to squamous cell carcinoma as well. There is some oxidation damage to DNA, cellular DNA, through other sources, visible light and infrared. I won't go into it now, but suffice to say that, photoaging is quite complex, and skin protection from the sun is paramount. So it's talking about photo damage and AK. So, skin gets photo damaged. And then what you see is scaly areas, red areas, always in sun exposed areas. And that leads to actinic keratosis. It's a warning sign, but when you see sort of an area here of unprotected skin, this also could move into more of a nodular form, which could then develop into a squamous cell carcinoma. Squamous cell carcinomas are dangerous, because they can, particularly if people are immunosuppressed, and a lot of your patients may be immunosuppressed, 5% of squamous cell cancers can be quite aggressive, and people do die of squamous cell carcinoma. So I would say that sun protection at any age is really, really important. And I'm always telling my older patients to sun protect, and sadly, a lot of them don't. The other thing you'll see, which actually sometimes can lead to ulceration and be a cause of leg ulcers, is Bowen's disease. And this is basically within the AK spectrum, but really is a patch of damaged skin. So it's sometimes called a carcinoma in situ. Again, it doesn't spread, and it is within the AK and not the squamous cell, but obviously it is a slowly growing scaly pink patch. So I would say always be alerted to your solitary pink patch. A solitary pink patch is more likely to be Bowen's disease or a BCC. You don't tend to get solitary pink patches with eczema, psoriasis, and of course the other differential could be a tinea. But these can often ulcerate and become non-healing leg ulcers. So these are some facts. I'm aware I'm a minute to time, but I won't run over too much. I was quite surprised when I did some extra research on skin cancer and older people. So you've got we talked about AK, and then skin cancer divides into non-melanoma, which is the basal cell and squamous cell. In terms of non-melanoma, are 90% of all skin cancers. Basal cell is about 70% of that group. Basal cell develops on the basal layer. This is the dermal epidermal junction, and grows upwards and is destructive, but does not spread into the dermis. The squamous cell, as I say, can be invasive, and this is about 30% of non-melanomas. Squamous cells there, we'll see some in a minute, but melanoma, I often say, can affect anybody 18 to 108, and develops from the melanocytes, grows up, either hits a mole and changes it in terms of size, shape, and color. Do revise your A, B, C, D, E. But at the same time, grows down vertically fast. It can grow rapidly within weeks. So it's really, really important to be alerted for any changes. And particularly, moles grow up to the age of 45. So any new moles growing in an older person should always be regarded with suspicion and should be checked. So non-melanoma, interestingly enough, 48% are diagnosed in people over 75, and 76% of non-melanoma deaths are in older people. And in melanoma, 29% of melanoma, which is the fifth commonest cancer in the UK, are actually diagnosed in people over 75, and it's increased by 149%. So I feel very strongly that there needs to be more information about skin cancer and incidence and prevalence in older people. Sometimes melanoma is said to be a cancer that affects younger people or middle-aged people. Absolutely not true. Remember, 18 to 108. So basal cell, just to give a bit of recognition really quite quickly, there are 5 types, but generally in yours, the common types, most common types are the superficial, which develops as this pink patch, or the nodular. The nodular often has blood vessels, and it also can ulcerate. So again, this may be within wound care a cause of a non-healing ulcerated area of skin. They are slow growing. They are non-healing lesions, and if you want to learn more about recognition of lesions, I would highly recommend you learning about dermoscopy for examination, which is just so helpful. Squamous cell are seen on sun-exposed sites. They tend to be nodular. They tend to have a very firm base. So you've got a firm base, and they're keratinocytic lesions. So they have a scale in the middle. So I always say basal cell carcinomas almost have a depressed sort of ulcerated area, and squamous cell carcinomas have scale which sort of rises up from them. So always look for these sort of lesions. Now, squamous cell carcinomas are the one that is generally tender and friable, and again, non-healing from the start. Basal cell has generally no symptoms of pain or tenderness, and surprisingly, perhaps melanoma often doesn't when it's developing. So melanoma, again, different types. And you'll see here, this is some dermoscopy where you see what we call clues in chaos, but even visibly on the skin, this melanoma does not look happy. We have an expression, pink and brown makes you frown. Amelanotic melanoma is where you don't have melanin. And again, because melanin cells reduce in older people, you may be more likely to see pink melanomas. Like this or like this, and also do keep an eye on nails. So I think the key thing is that these are 2 really good images that look at non-healing wounds that may actually be skin cancers. So, this is a wound which, obviously I know one of the hardest wounds to heal, ulcers on the foot, particularly on the heels. But actually, the reason for this non-healing wound was actually that it was a progressive amelanotic melanoma. And this little sort of lesion on the toe, again, completely non-healing, was actually a small squamous cell carcinoma. So I suppose the message about telling you a bit more about skin cancer, because you will be observing all the skin of your patients, and patients may ask you or may alert you to skin changes, is that just always remember that non-healing wounds may also be skin cancers. I thought they were really good examples and quite interesting. So in conclusion, structural and physiological skin aging compromises wound healing. Be aware of the endogenous skin aging and the impact on skin integrity. Patient education is really important to reduce that impact of endogenous skin aging. Obviously, sun protection, healthy diet, trying to reduce some of those factors, and photo aging is key. And remember, with non-healing ulcers, there's always have a low threshold for suspecting skin cancer. And I'm sure some of you probably have experience in finding a skin cancer which was thought to be an ulcer. So I have just run over slightly, but we've still got 10 minutes for questions. So hopefully that's okay, Sarah. These are my contact details. I'm afraid my website should be up and running soon, but I'm having a bit of a revamp at the moment. But you're very welcome to contact me on my my email address. I'm not so good with X. I used to be really good with Twitter, but I need to get back into it. But thank you for listening, and I really, really hope it's been a helpful presentation and practical as well.
Thanks, Julie. That was absolutely fascinating. It really was. I think it's more than a refresher. I think the detail given, I'm sure will be just, the comments are coming in now about, how people have enjoyed that. Let's have a look at the questions. I know, just first of all, there was a question from Cynthia Silver. You're asking to know a bit more about emollients. So hold on to that, Cynthia, because we actually have got a session on emollients. I think it's our last presentation today, so at 2:45. So you will get more about that. So it's not that we're ignoring your question, but thank you. Let's just have a quick look. I was fascinated about interested about the reference, Julie, to around vitamin D, because we know that a lot of elderly people, particularly if they're not very mobile, they don't venture outdoors, or they're in maybe residential or nursing homes. And I know there's more and more being talked about that, particularly in non-healing wounds. But would you suggest then that, if you've got an older person with a skin condition, that should always routinely be checked? Because I don't think GPs automatically think about that, do they?
No, I think vitamin D is hard because I think there are some mixed messages. It was interesting because I had a patient the other day who had a hair issue, and she said her trichologist, who knows how they were trained or registered, because it's one of those professions that she just said, you've just got to get as much sun as possible and just blast yourself. And I was going, no. She had very fair type 1 skin, and I said, you need to take vitamin D. Why wasn't that suggested? And she said, well, I do take vitamin D, but I've still got low vitamin D. And I said, well, how do you take it? And she said, well, I take it as a multivitamin. And the problem is that multivitamin tablets often have a lower dose of vitamin D. So you need to make sure that you've got that it's at the 10,000. I never know. It's the micro units, but anyway, there is a set amount. So I think it is worth checking vitamin D, because sometimes it might be a more medicinal dose. But whether older people, particularly between the months of October and April, where you don't get any vitamin D from the sun. I mean, the question is, should we all be taking a vitamin D supplement? Personally, I do. But, it's whether it should be put into a general health measure, or, we should lobby the government really to add our vitamin D levels to milk and things like that, really. Because I think, you do get vitamin D from the sun, but you need more as you're older. The other thing is, if you have a skin type 4 to 6, so if you have black skin of color, you need more vitamin D as well. But I think it is worth checking if it is something that is worth checking, because vitamin D can make an impact, and particularly for eczema, we do know there is a link with low vitamin D and eczema.
Thanks for that. I'm aware we're at time. Maybe I think there's a lot of comments really, things like around raising awareness, and do you think that awareness around skin conditions, or certainly skin cancers, has improved over the recent generations? One thing that I was thinking of is thinking about the older people and those people that care for them, who often will be doing a lot of personal care, and maybe that's who we need to target about, if someone's being bathed or washed, it's being aware of these lesions that maybe the patient isn't aware of, that might need looking at and maybe sort of biopsying. So I think there's some sort of work maybe to do with our carers as well, I think. I'm not asking you to comment necessarily, but I think that's what maybe we need to be aware of. Thinking about things like our skincare champion
I was going to
program.
say, I'd be
Yeah,
very happy to do a session on recognizing skin lesions and when to
yeah,
because and also the PCDS are getting more and more interested in just getting that basic education to not only carers, we're thinking even people who provide general services, beauty therapists, even
yeah,
tattoo
yeah,
artists, because they're the people seeing skin people who do massage.
yeah.
Yeah. So I think it is really important to recognize. I'm interested, and there is a question, if I could quickly answer it, what is the pathophysiology of itchy skin around a mole? And that's quite interesting, because people always worry about the symptom of itch and think itch is a main symptom of skin cancer. It's not necessarily, because a lot of skin cancer, it's the visual changes that you're seeing first. And itch, often people get worried about a mole and psychologically just go to rub it, and then it becomes itchy, or a normal mole like a dermal nevi, a raised mole, catches on clothing and becomes itchy. So we often say that itch can be significant, but we find it the least worrying sign. Actually, it is all about the change. But as I say, it's not a skin cancer lecture. Happy to come back and do something like that another time. Happy to help with the champions. And as I say, it was a lot to fit into half an hour, but around the topic of the physiology of aging skin. So, and there's
Yeah,
some,
so
can GPs prescribe loading doses of vitamin D if levels are low? Yes, absolutely. GPs should be doing that, and prescribers. Yeah, I'm not sure most of you are prescribers.
okay, thank you again, Julie. That was absolutely brilliant. And as I said,
Yes.
through the comments being made, people really enjoyed that.